All right, in this clinical review, we're going to do a focus dive into the key congenital ichthyoses, those inherited disorders of keratinization.
Okay, so here's our game plan. We'll start with the absolute core defect. What makes ichthyosis, well, ichthyosis? Then we'll tackle the three major subtypes one by one: vulgaris, X-linked, and lamellar. And to wrap it all up, we'll do a comparative analysis to really lock in the key differences.
So, at its most fundamental level, what are we talking about? Ichthyosis is a disorder of keratinization. The name itself is a huge clue. It comes from the Greek word for fish, which points right to its pathognomic sign, those fish-like scales. Now, and this is absolutely critical, this scaling happens without primary information. That's a huge diagnostic differentiator you need to keep in mind.
And here you can really see that clinical spectrum we're talking about, comparing healthy skin to the characteristic scaling you see in ichthyosis. The root of the problem? It's all about defective desquamation. Basically, the normal shedding process of the skin is broken, and that leads to this very visible, often dramatic buildup of scale.
All right, let's start with our first subtype, icthyosis vulgaris. This is the autosomal dominant form, and you're going to see this one the most. It's the most common of the bunch. So, we already said the inheritance is autosomal dominant. The genetic driver behind this is a defect in the phenylagrin gene. And you know how crucial phenylagrin is, right? It's essential for pulling those keratin filaments together and maintaining the integrity of the epidermal barrier. So when that's defective, well, the clinical result is exactly what you'd expect, that classic presentation of fine, white adherent scales.
Okay, moving on to our next one, X-linked ichthyosis. It also goes by the name icthyosis nigra, and that name alone gives you a big hint about its distinct clinical look.
With this one, we're really talking about a biochemical pathway. It's an X-linked recessive condition, and the culprit is a steroidal sulfatase deficiency. So you get this enzymatic block, which then leads to an accumulation of cholesterol sulfate right there in the stratum corneum. And that's what creates those persistent adherent scales that present clinically as these larger, darker, almost brown-black plaques.
And it's really important to remember that the role of this enzyme isn't just limited to the skin. There are a couple of key systemic associations you absolutely have to be aware of. First, corneal opacities. They're usually asymptomatic, but they're there. And second, cryptorchidism, or undescended testes, in the affected males. And that brings us to our third main type, lamellar ichthyosis. This one is autosomal recessive, and what really makes it stand out is its incredibly dramatic neonatal presentation. The core defect here is with the enzyme epidermal transglutaminase 1, which is absolutely critical for forming that cornified cell envelope. So at birth, these newborns often present encased in what's called a collodion membrane. It's this taut, translucent, almost parchment-like sheath. Over the first few weeks of life, that membrane sheds, and what's revealed underneath is the mature phenotype. These large, dark, plate-like adherent scales that cover the entire body. There's really no sparing of any skin surface. Now, all of that severe hyperkeratosis creates significant skin tautness, and that pulling leads directly to some classic structural deformities. The two you'll see most notably are ectropion, that's the eversion or turning out of the eyelids, and eclabium, which is the eversion of the lips. Okay, so we've covered the big three. Let's pull all this information together now. A side-by-side comparison is really the best way to highlight the key features that differentiate them. This table really lays it all out nice and clearly. And I want you to notice the direct correlation here. It's a perfect cascade. The inheritance pattern, right? AD, XLR, AR, that dictates the specific molecular defect. Is it a structural protein like filaggrin, or an enzyme like steroid sulfatase? That defect, in turn, is what drives the scale morphology, the fine white versus the dark plate-like scales, and those very distinct systemic associations. And remember, those associations are absolutely critical clues when you're working through a differential diagnosis.